Everyone. Good morning and a very warm welcome. My name's Rammya Mathew. I'm a GP and I'm also Divisional Medical Director at Central London Community Healthcare NHS Trust. It's really great to have you all join us. Before we kick off though, I want to make sure you're all in the right room. So I'm going to share the title of this particular workshop. So we're going to be revisiting the role of improvement to reduce wait times in the early 2000s. What should we be learning and how have we moved on? So that's the question we're going to be exploring today. So if that's what you're expecting, then great, you're in the right place. But if by any chance you've slipped into the wrong workshop, then this is your time to make a quick exit. I'm going to go through some quick tech bits with you. Firstly, to say that this session is being recorded. So kind of can ask you all to stay on mute while we're having the panel discussion, but there will be an opportunity for questions later on. So I will bring you in at the appropriate times. We're also going to be having some breakout groups as well. Do turn your videos on. So it really does enhance the experience for everyone and we really encourage it. I know that occasionally there are sort of emergency phone calls and things that you have to take. So we absolutely understand that. And there is an open chat as well. So if you've got comments, reflections, then please do add that in the chat as you go along. We're also on social media. So if there are things that you are tweeting about, then put the hashtag Q community event and others will all be able to follow the discussion as well. And if you want to use subtitles for the session, there's a live transcript button that you should be able to press and then subtitles should come up on your screen. And if at any stage you are struggling with the tech, then our Q team are at hand. So please do contact one of the hosts via the chat and they will be able to help you. Just to run through the format of the session. So as I briefly mentioned, we're going to have a panel discussion. We've got 3 great panelists with us today. And then following on from that, we're going to go into breakout groups. So that's your chance to build on the discussions that we've had and to sort of explore that within a smaller group. And then we're going to be coming back into a Q&A. So you can feedback what you've been discussing in your small groups, but also put your questions to the panel members as well. I'm going to just talk a little bit about this topic now. So just to introduce it. So NHS waiting lists are, you know, it's such a big topic at the moment, isn't it? And to put this into context, I'm going to share a statistic with you. So going back to February 2020, so that was just before the pandemic hit, we had 4.5 million people on an NHS waiting list at the time. And that does sound like a lot of people already. But fast forward 2.5 years, and the latest statistics as of August 2022 is that we now have 7 million people waiting for care or treatment on an NHS waiting list. And this isn't just numbers, this is people's lives. So we know that being on a waiting list is not a neutral position. In fact, people's conditions evolve, they develop complications, the risk of them undergoing procedures becomes increased. So this is making a real tangible difference to our patients, but it's also hard for those who provide care as well, because they're also managing these risks. So this workshop is going to be an opportunity for us to look back at what has happened in the early 2000s. So a lot of work went on at that time to reduce waiting lists, and there were a lot of successes. So we've got 3 panel members who were involved in that work and are going to be sharing their insights, but we're then also going to be looking at the current time. We're going to be looking at the current context, the current challenges. What do we need to hold on to that has worked previously, but also what do we need to do differently going forward? I'm now going to hand over to Matt, who is going to give us some warm-up questions just to get us going, and then I'll introduce the panel to you after that.
Fantastic. Thanks so much, Rammya, and good morning, everyone. So yeah, we've just got 3 questions to get you all warmed up. Chloe, could you just skip the slides on a little bit? I think it's just, yeah, keep going, and we'll get to our first question. Great stuff. Okay. So yeah, please just answer this really briefly in the chat. Like I say, it's just a way of getting everyone warmed up. So firstly, what's your role in relation to reducing waiting lists? Just really briefly in the chat, just so we get an idea of who's with us today. Good stuff. Keep them coming into the chat. Great, good stuff. Yeah, some people obviously working directly in this area, some less so, but I think that the discussion we have hopefully will be really useful for lots of different perspectives. Great stuff. Keep those coming in. So on to the second question, Chloe. So one slide on, please. A little bit trickier. How do you feel when you think about the waitlist challenge? How do you feel when you think about the waitlist challenge? So just in one or two words. Anyone raise it? Oh dear, yeah. Not surprising given the scale. Yeah, demoralised, frustrations, I guess. Challenge, okay, we've got a slightly different framing. Yeah, there's opportunities as well, isn't there? But yeah, certainly the kind of scale of the challenge is huge, isn't it? So hopefully we'll make a bit of progress on that today. Great stuff. Thanks a lot for sharing there. And then on to the third question, Chloe, to the next slide. This is quite a big one. How do you think improvement has changed in the last, to just shoot from the hip on this, you know, just give a kind of quick reflections. Obviously, some of you have been working in improvement for 20 years. Dare I say some maybe more than 20 years, but just draw on your experience. How do you think improvement's changed in the last 20 years? More accessible, more visible. Yes, some really positive framings there. Yeah, so we've got the scale of the challenge, haven't we, of the waiting list, but then obviously, hopefully some, you know, real positive developments and contribution that improvement can make. Great stuff. Okay, hopefully everyone's brains and fingers feel better warmed up after that. I'll hand back to you, Rammya, to introduce the panel.
So we've got a great panel lined up. I'm going to start off by introducing David. So we've got Sir David Dalton, who was former Chief Executive at Salford Royal NHS Foundation Trust, and he's also a governor at the Health Foundation. David, do you mind just giving us a wave? Great, thank you. And then we've got John Boulton, who is Director of NHS Quality Improvement and Patient Safety at Improvement Cymru. John, could you give us a wave as well? Great, thank you. And then we've got Ailsa Brotherton, who is Director of Continuous Improvement at Lancashire Teaching Hospitals NHS Foundation Trust. I'm going to hand over to David, who's going to kick us off. Just a quick reminder that we've all got about 8 minutes each, so I will keep you on time and bring you in if I need to. Great, thank you, David.
Well, thank you very much, and hello, everybody. Hopefully, I am unmuted. I've just got a box up that tells me that I may not be.
No, that's great, David.
Okay, thank you very much. So I've been asked to press the rewind button and take us back a little bit in time in history, and I'm old enough to remember what it was like when we accepted that improvement was done from the top down into the organisation. I started in the NHS in 1979, and I thought I would just remind you of two significant documents that were available, these two that are in front of you, one that was written by the then Modernisation Agency called 10 High Impact Changes, and the other with a catchy little title there of 7 Ways to No Delays, which was produced, you'll see, in 2017. There have been many documents and many wise sages telling the NHS what it should do in order to make improvements to waiting times. So let's have the next slide, please. And if you actually open these documents, and I don't know whether anybody is familiar with them, but when you have a look at the Modernisation Agency's approach and you see their 10 high impact changes, the summary is here on the slide in front of you. There's a lot of good stuff here, really. Not any advice here that you would find difficulty with, perhaps. And then later on, when you have a look at the next 7 tips, again, these are perhaps very familiar to us now. So what I really wanted to say by showing these is that the NHS has been familiar for a long time, over the last 22 years, of being told what it should do, but perhaps rather less on how to achieve it. So let's move to the next slide, please. And for me, this is my last slide. And really what I want to do here is to take you through the next 5 minutes a journey over the last 22 years. And let me start in the year 2000 then, on the left-hand side, where you'll see the NHS was very familiar then with the government's approach to setting targets, being clear on what it expected. And in those heady days, it was for nobody to be waiting longer than 18 weeks for access to their treatment. We reported a lot of information upwards, and there was an expectation that there would be strong performance management from the centre. At that stage, there were theories for improvement, but not many of them introduced into the NHS. You may remember Helen Bevan and the approach that she took with colleagues in Leicester, and lots more stories were then introduced to the NHS. But we were unfamiliar and therefore welcoming of the Modernisation Agency. I have to say that the focus was also then on improving patient safety, and many of you may remember the awful tales of infections, both MRSA, C. difficile, and others that hospitals or their patients were experiencing. Moving us on then over the next 8 years, people began to look and were interested in methods of improvement. For myself, I started to take an interest at Salford Royal, where I was chief executive, of what the Institute for Healthcare Improvement were doing and what they were advising some of the better hospitals across the world were doing in making improvement. My interest, I have to say, was predominantly applying that to patient safety and harm reduction. But the principles were the same, and we were beginning to see how they could have their application onto to waiting times as well. Now, I'm not here to suggest or be a proponent of a single methodology. There are many, but they're probably accepted to be variations on a theme. I don't know how you would describe these, but there are some of the things that I think were important at the time. Lots of people becoming familiar with PDSA cycles. Moving 8 years on, and people were recognizing that you couldn't push improvement into the NHS. Far better that it was pulled, far better that staff were feeling empowered and involved, and they were given the power to try and test changes, so long as they were measuring them and reporting the results and seeing what worked and whether that could be spread to other parts of the organisation. Those who were interested at the top of organisations could see that by deferring to people who had knowledge and expertise, this is where you were going to get the most or the better ideas for disrupting and changing the system. Also, we started to hear of microsystem coaching as an approach to get the best out of teams, coming up with ideas deep inside the organisation. Moving to a more recent period, many of us now familiar with the response to COVID, the requirements for us to be much more agile in looking at the deployment of ideas into organisations rapidly. And at the same time, a view that not only could you get better improvement if you're involving staff, but you could get better improvement through involving those who experienced your services, an interest in how fragmentation could be avoided, looking at pathways crossing organizations, seeing that collaborative behavior was really important. So this idea of co-creating with your workforce, co-creating with your users, and co-creating with other organizations who are taking responsibility for the health of the population. Now, the NHS at that stage organisationally over the last 20 years had developed other organisational responses, foundation trusts, lots of organisations involved in the space. And an interest was developing about how people could work together and operate at scale, and will now be familiar with some of the things that we're being asked to consider with diagnostic centres, separating hot and cold sites, the development of surgical hubs. So moving to where we are now, we can see that people are writing now about how you transfer knowledge and experience rapidly through networks. There is the beginnings of understanding how AI can be doing a lot of the processing work to identify things and show things to decision makers that weren't available before. Technology is also very much at the fore of being able to utilize that to keep people out of hospital, to be supporting them in the management of their own health in a very different way. We have constraints, which I mentioned there, most notably those of the lack of workforce. And I just want to end in saying that perhaps the next period of time is going to be focused on what I've called delivery management. How do you assure reliable implementation of change and that it sticks? I shall end there and hand back to you.
I'm going to move it straight on to John, if that's okay. Thank you.
Thank you, Rammya. Thank you, David, for that presentation. I'm not sure I can beat the last slide, but just to sort of introduce myself in terms of my background, is I started as a consultant nearly 15 years ago and got very interested in improvement, working through waiting lists and looking at my own waiting lists, but also more broadly at the outpatient service in Sheffield. And I just want to give maybe a sort of parallel stint to what David said. So if you can just move on my slide, please, Chloe. So I want to start talking about Tesco. And I know it's probably an odd thing to talk about when we're talking about improvement, but in 2021, Tesco opened its first checkout-free store in Holborn in London. So that was a first for England, although there are a few checkout-free stores in the US. But you'll see from the storefront is what it says is no queues. So why am I talking about Tesco on this presentation? Well, Tesco's are recognised as one of the world leading experts in the science of waiting and queues. But what they've been on is a journey from a similar period of time to the NHS, in terms of they started around the early 2000s getting very, very interested in the science of waiting. And if any of you remember back to the adverts of the early 2000s, the advert went something along the lines of, if there are more than 2 people waiting in front of you, we'll open another till. That's a really great application of thinking about waiting. And they've been at this now for this probably about the same time that we've been thinking about waiting and the challenges around waiting within the NHS. So if you'd move on for me, Chloe. So at around the same time of Tesco's starting to think about queuing, we started with something called the Emergency Services Collaborative. It was my first introduction into improvement. That was led by the Modernisation Agency. And as David described earlier, is it then morphed into something called the Institute for Innovation and Improvement. And I think at this point, this is where, for me, at the least, there was a huge interest in improvement science. So how we applied industrial principles into the health system. But it was more than just PDSA cycles. It was more than the model for improvement. It was more than statistical process control. It was much more broader of improvement science. So queuing theory, how we think about lean, how we think about things such as the theory of constraints. And one of the things that I think was so fantastic at that time is that we had a really large, significant coalition of really deep experts from industry as well as within healthcare. It was accessible. There was a great deal of innovation at that time, whether it was the work that David described that Helen Bevan was doing within Leicester, the productive ward, but also started to think about change at scale and the importance of not just leadership, but that bottom-up frontline engagement. Next slide for me, Chloe. In Wales, roughly around the same time as the NHS Institute formed, we had a similar thing happening within the nation of Wales. 1,000 lives, huge energy, huge excitement, leaders, academics, improvers, analysts, all coming together from different disciplines to think about how we apply all of this new science, which was relatively new at the time to the NHS. What was a patient safety campaign broadened and started to think about waiting lists and the science of flow. And this is perhaps one example of what we then started to lose. Shortly afterwards, the NHS Institute was dissolved. Yes, I know something else changed it, but at the same time, the campaign of 1,000 lives morphed into a set of programs. Leadership stepped back, improvement became PDSAs and run charts, and perhaps the science of waiting, queuing theories, etc., perhaps was put back on the bookshelf, and some of the disciplines stepped away. Next slide for me, please, Chloe. I think it's one of the things that's really important for us to actually think about. Healthcare isn't Tesco. It's much more complex, and the application of things such as queuing theory really does need to be taken off the bookshelf and really brought back to the fore. So the work that I was doing around the late 2000s was really focused at looking at waiting lists within outpatients. It was a great time. It was interesting. There was relatively few looking at it, very much consistent with what was going on at the time. We were looking at understanding the system through the lens of system dynamics, demand capacity, all of these things which really got me excited. We tapped into that national knowledge, and I was really fortunate to be mentored by some really great national experts. But one of the things that we managed to do through the application of that wider science is really think differently and innovatively about how we think about waiting. And as a consequence, we took a microsystems approach, which I know Ailsa is going to give you a great example shortly. Next slide for me, please. So one of the things that I think that we've lost, and I think I would really like to see us get back, is the link between mathematical modelling and simulation with improvement. And there's some great examples at the time in the late 2000s as we were starting to bring all of these tools and techniques together. But what I would say is in the 2020s, we're still really struggling to bring them together. Yes, there's some pockets of really good work. And Iron Bevan Health Board in Wales has got a great example of a combined team. But this was a model that we built to actually understand the flow and how queues form within outpatients. And each of those grey circles has an impact on the flow through that clinical service. Suddenly we could see the complexity. Suddenly we could challenge ourselves in the mental models that we had. And this is a tool, this is a methodology that we're not using enough to actually understand the science of queues. So move on for me. So this is the output from that model. And what you'll see is the actual queue that is formed there versus the simulated queue. And this was a colleague that I tracked over 3 years to actually see how their clinic queues actually grew. Now, the model's not perfect, but it was good enough for us to make decisions, for us to test on the ground and test on the fly and really challenge ourselves how we understand system behavior. One of the things it does tell you is never start a waiting list initiative clinic. So last slide for me, and I'll move over to Ailsa with a really great presentation. So some learning for me, and these are the things that I'd really like us to think about how we rebuild these and revisit it. The first one, the energy for improvement in the 2000s as we're introducing these methods, these tools, these techniques was significant. There was a lot of excitement. It was new, it was different. Leadership was heavily involved. And it was to some extent nationally coordinated. Maybe we've lost some of that energy. Maybe we've got a few more cynics, but I think as we start to reset, I'm starting to see that energy return, which is great and it's fantastic. There was a huge amount of innovation at the time from us applying those industrial principles, how we start to think about things like queuing science, theory of constraints, and it led the way to terms such as carve-outs and bottlenecks. We were developing products at a rate of knots at that point. So whether it was a safety thermometer, the productive series, more broadly, the LIPS programs. And again, it's something we maybe need to revisit and rethink about, is what are the products in the improvement science realm that we need to actually bring in that supports all of the technology and the innovation work that David's just described. But the other thing is innovation in 2020, certainly from where I sit, seems to be seen as separate from improvement. It isn't. They're two sides of the same coin. Other nations may be different, but in Wales, to some extent, we've lost some of our infrastructure, both at a national level, but also at a local level. And as I said earlier, we sadly lost the NHS Institute. And whilst the NHSI replaced it, we lost many of those great pioneers and those real deep experts at the outset, which brings me to my last point. Now, there's some amazing people on this call. Some of them I get the opportunity to work with on a daily basis. We've still got great capability within the healthcare system. But one of the things that we really do need to build is that deep expertise to actually understand weighting at a different level. And it's much broader than just simple improvement science and the way that maybe we think about it these days. I think there's some great shoots that David's described there, and I think that you're going to see a great presentation from Ailsa in a second, is that I think we're starting to recognize the need that we need to broaden some of the learning, some of the sciences that we're actually thinking about. And people are starting to talk, as we are here, how do we really tackle these waiting lists? And I think Ailsa is going to provide you with a really great example of some current work that's really focusing on that. Thank you.
Thank you very much, John. So if I could have the first slide, please. And if my sound dips out, please do let me know and I'll turn my camera off. So in terms of the work that I'm going to describe, I just want to start by saying a big thank you really to David and people like Maxine Power and Tom Downs in Sheffield. I've had a great opportunity over the last decade to really learn from some of our national leaders in improvement. And really what we're trying to do here now in Central Lancashire is take that decade of learning that really sort of builds on some of the work that John's just described from some of our organisations and teams that have really applied the theory well. And what we're trying to do now in Central Lancashire is really build an improvement approach across our entire system. And the first thing I would say is that is incredibly complex to do. So it's not going to be a quick apply.
I'm just jumping.
The methodologies.
Sorry, your sound is jumping out a little bit, Ailsa.
Okay, let me stop the video. And hopefully that will make it better. Thank you. So in terms of applying that learning, the one thing that we're trying to do is to really take the learning and design improvement at a system level. So we're really looking at systems within systems within systems. So I just want to share with you how we're really approaching adopting improvement to reduce our wait times in Lancashire. So the first thing we're doing in Central Lancs is working at that microsystem level. And David shared some of the early work around microsystem coaching from Salford. And actually what we're really focusing on here is supporting our frontline teams to really deliver the work in the way that we know is needed. So we have got some of our theatre teams, some of our ward teams, some of our ED teams really working on reducing the weights that are within their gift. Now, this work is really challenging and we know that sustainability is a really key issue for us. But you can see here just some of the early work that we're doing and some of the improvements that you can see in things like ambulance turnaround times. Next slide, please. We're also then working at that next level too. So we've got our microsystem coaching academy that really looks at every individual ward and department. And we're not there yet in terms of building the capability and capacity, but we have started on a journey to train all of our clinical areas in a microsystem coaching approach. The next level is the pathway level, so our meso level. So we now have over 20 big rooms established at Lancs Teaching Hospital, which really uses the methodology of the FCA. And a big thank you to the Health Foundation, who really funded and supported.
Ailsa, we've lost you again.
National Flow Coaching Academy network. We have learned so much from those teams. So in terms of some of the weight, you can see here that we have focused a number of our big rooms on reducing things like our clinic weights in our ENT big room. Our frailty assessment unit has really reduced the length of time that patients are waiting for admission from the ED to the acute frailty assessment unit. And a big room, I've just seen the comment, Kath, thank you. For those of you not familiar with a big room basically is the improvement methodology that the Flow Coaching Academy uses that brings together team members who are involved in the delivery of a pathway. And one of the reasons this is really important is many of our pathways in healthcare are really complex, and actually we know that you need people to work from different teams across our organisation and across our wider community teams to really improve. And you can see there if you look at that lung cancer big room, you can see there where we had delays in our lung cancer big room, and they've now reduced the time it takes for a CT scan to be requested for patients. If we can multiply this across all of our clinical pathways where we know there's a significant issue in terms of our waiting times, then we really do build the critical mass of improvers across our organisations and systems. Next slide, please. And then we're also focused in Central Lancashire on the macro level. And this is really, I think, some of the learning that we're trying to take from Salford. So when I worked in Salford with Maxine, David and Maxine set up an improvement team called Halo that was really working across the entire city. So working with local systems together well, and that's what we're trying to do across Lancashire and South Cumbria. So we've got this work underway at 2 levels. So within our organisation, those problems that are really quite wicked to solve across divisional teams, we are bringing teams together, and we're just setting up a system coaching academy to take the same methodology and really looking at some of the theories that John described about how we can really learn from queuing theory and really reduce the delays across the complexity, which is multiple teams within our organisation. And what we've done, again, taking the learning from Salford, we were particularly keen to think about the impact of improving safety to reducing delays. So actually, if we deliver harm-free care first time, then patients have a lower length of stay. So what you can see on the left of this screen is our safety surveillance system, and this really builds on Professor Charles Vincent's work, where he really talked about and described for us how you measure and monitor for safety. So this is our example. So this is used on our wards daily now. It informs the level of safety that our patients receive in terms of the care they need. And you can't see the detail on that screen, but it shows our ward teams where patients are waiting for things like risk assessment. So how many patients haven't yet had a risk assessment, and our coordinators use this to make sure that we are improving the care for patients whilst they're still with us. So we're trying to make that shift away from looking in the rear view mirror to actually looking at what can we improve while the patients are with us. And this is really starting to impact on our length of stay. Next slide, please. And then finally, this is our work at an ICS level. So we have worked with other improvement leads across our ICS. So the 5 providers that you see there on the slide are coming together, working in partnership with Cambridge University to really look at how we can embark on adopting improvement at an ICS level. So we are working in partnership with Professor John Clarkson, and this So when I first did the Generation Q Fellowship, I naively said I wanted to learn as part of the Gen Q programme how to do improvement at a system level, and almost a decade later I've still got more questions than answers. But actually what we are trying to do here is agree the scope of our work and work together to make sure that actually improvement is embedded for our big priorities for the ICS. So you can see here that we are working first of all on frailty and respiratory. We've undertaken a diagnostic, and we know that those two areas are where our patients are. Currently, we have unmet need, and we have patients that are waiting longer than we would want them to be. So this is the model, and we've established a way of working that we want to design a bespoke improvement model that will work at an ICS level, to really focus on maximising the contribution of improvement to the challenges that we've got in terms of dealing with our waiting lists today. So that's my final slide. If I could ask you to stop sharing or to move on to the next one, please.
Great, thank you, Ailsa, and thank you to David and John also. It's pretty clear from your presentations that improvement has really evolved over the last 20 years, but actually a lot of the work that went on in those years is still relevant today, whether that's the 10 high impact actions, elements of queuing science, or the microsystems approach. And actually I really enjoyed, Ailsa, all the current examples that you've given, because it shows that actually this stuff still does work. We do have, you know, a monumental task ahead of us because of the waiting list, and also there's all sorts of other challenges around workforce, burnout and so on, but all of this still applies and it is still working. So that does give me some hope, and I hope it also gives everyone here a sense of not feeling so overwhelmed, but feeling slightly energized as well going forward. We are going to go into breakout groups. I'm going to hand over to Matt, who's going to talk us through how that's going to work.
Great, thanks very much, Rammya. So yeah, like you say, hopefully we're going to take some of that kind of energy and inspiration from the speakers into the breakout groups. So we're hoping this is going to be a great opportunity for us all to kind of reflect in smaller groups on what we've heard, but also bring in our own experiences and challenges that we're facing in our own work. So if you just go on to the next slide, Chloe. We've got about 25 minutes for the breakout groups. There will be self-facilitating of about 7 to 8 members. So like I say, lots of people will have different levels of experience, but we really think everyone's going to have a useful and valuable perspective to bring to these questions. First thing to do in your groups is please just nominate one person to feedback kind of 2 to 3 key points to the whole group when we come back together, because we are going to come back for a good kind of Q&A at the end. And then we've got these 3 questions for you to go through in your 25 minutes. Start with a round of introductions, get to know everyone, your name, your role, if and how you're working to reduce weights. Then move on to the second question, which is, what can we learn from the role that improvement played in reducing wait times in the early 2000s, and how have they moved on? Like I say, some of you will have more direct experience of that. That's fine. Everyone will be able to bring their perspective to that. And then we really want to make sure that you do have a bit of time in your groups to focus on this third question, because that's what we're all facing at the moment, isn't it? How can improvement really play its full role in reducing waiting lists in the current context? We've had the changing context, new challenges, but all of that learning that we've got around how improvements developed, how can we really support it and make sure it's playing its kind of full role? Okay, and what we'll do, given the size of the group, we'll just ask people to feedback verbally, actually, when we come back together. So we should just have 3 or 4 groups, I think. So that nominated person, just be ready to feedback verbally. Any problems in the breakout groups, just let Sarah Koo know, and she'll be able to help you with that. Otherwise, we'll see you back for the Q&A in about 25 minutes. Great stuff. Welcome back, everyone. Yes, I hope you had a really useful and rich conversation in your breakout groups. Just before we get into the Q&A with the people, I'm just gonna ask one person from each group to feedback kind of 2 or 3 key points really briefly, and we'll do that verbally if that's okay. If there's any issues with your mic or camera, then feel free to add them to the chat. But yeah, it'd be nice, I think, to hear from people. So firstly, can we hear from Geraint and Olivia's group? That was the group that nominated Bakara was.
I think that was my group.
Yeah, that was it, Rhiannon. That's you. Yeah, go.
Okay. The conversation wandered. We came up with our 3 points. One of the discussions was around the embedding of QI methodologies within organisations and the challenges of that, and how is it that you end up with some people who really take it on and run with it and it becomes part of the DNA of how they work, and others don't, and they're in the same organisation. And so a lot of our discussion was around how you try to fix that issue. One suggestion was that QI is like an add-on to training. So you train, you qualify, and at some point later you're expected to take on QI as this add-on, and it's not considered to be part of the DNA of how you work. And so could we look at embedding QI at an earlier stage into pre-registration training? It was mentioned that medics are already expected to do QI as part of their training in 4th and 5th year, and then when they go into F1. But we then also were talking about the fact that other professions are trained in other ways, that you'd need to find different solutions, and the workplace works differently when they qualify. It's not as structured as it is for medics, but having it at that earlier stage so that everyone coming through the system is trained in QI and understands it and how to use it. Another thought was that it would be helpful. A lot of the people in our room had a similar issue, that the organisations they work for have nominal support for QI from senior sort of exec teams, and there's sort of interest at the bottom, but it doesn't come down. It's not, when you get into that middle, it's not really embedded in the organisational priorities. So people are still judged on their waiting lists, their appraisals, all those sorts of operational issues. They're not expected as part of their job roles to do QI, to embed QI, to use QI as how they work. And so it sort of fails at that point because of the pressures of the system. So whether Q community could come up with like a self-assessment tool for exec boards, to do a what does good look like in terms of what does a good QI organisation look like, and then they could sort of assess, and it might help to drive change within organisations to making it more part of how we do the everyday.
Sorry to jump around, but we've got a bit more time at the end to bring any more thoughts on. Okay. The other groups, if that's all.
Sorry.
No, really appreciate it. Okay, on to the next group, which was Des, Joe, and Michelle. I'm not sure who the nominated feedback.
Yeah. So we also had Piers and David and Katie. So I think we got into a bit of what's different to what it was in the 2000s, really. So there were some things that made it a bit easier then. Life was, like, in some ways, life was simpler. There was less expectation that we managed patients while they were on the waiting list. We were more kind of deferential about the way we received things. There was less expectation of involving patients and carers and so on. And we were more kind of deferential to the centre. So there was, and it was easier to get people to do things. There was less subspecialisation. There weren't the issues with pensions, all those kind of things. So it was a simpler, more straightforward world then. So that was the main thing that was easier, and also perhaps also the point that John made about energy. Everything was new, and also we were in a situation where things were improving, which perhaps made it a bit easier psychologically as well. But in terms of what we could do, in terms of the areas where there's greater opportunities now than there was then, we talked about two main areas, I think. One was in terms of the connections and learning from each other, which is easier than it used to be, given the variety of technological platforms that now exist to enable us to do that. Some of us there were some examples in the group of different programs and things that people had been involved in or particularly valued in that regard. But also we got onto a bit, we could definitely have used a bit more time, but we got onto a bit as well about how the other real opportunity that's different now and as compared with the early 2000s that needs to link improvement and basically how you harness the power of people in transforming their own care. And we've obviously done some of that in in the world of healthcare over the last few years in terms of the technological opportunities which are now available for people to do far more things themselves, from, you know, in terms of replacing face-to-face follow-ups, outpatients with other means of seeing people and so on, and how we kind of managed to build on all of that to build a real kind of transformation in terms of the extent to which people are able to take ownership for their own care.
Right.
And how we remember the experiential aspects of that as well. So we didn't have time to pull together a nice summary, but I think that hopefully summarizes some of the discussion we had.
That was beautifully done. No, thanks so much for that, Joe. Okay, on to the next group. So it included Dimple, Lorraine, and Kath. Not sure who's feeding back.
It's me, and I've already apologised in the chat because there's quite a lot, so I'll try and condense that.
Yeah, just pull out a couple. That'd be great, and then we'll have more.
Sure. So in terms of what we can learn, we talked about the energy and how much it's changed since the early 2000s, how high it felt then, and kind of on the floor it might feel now. We recap the place where technical and human meet and how precious that is, and what we can do as improvement advisors to create spaces so that when our people do give their limited time and energy for improvement work together, they feel like they've moved forward and made a difference to the challenge they're facing. We kind of segued into the second question about what's needed to ensure that improvement plays its full role in the waitlist challenge we have now, around maybe people feeling that QI training might be too onerous, and that sometimes measurement and data too onerous. These are all points that have come up through the presentations this morning, I think. And we talked about how we need to help people use that data and have measurement for improvement that's data over time that's accessible to people, and making the most of our digital interfaces, our opportunities for visual management, and also that we need improvement expertise to identify how we're doing using that data and what priorities people have for improvement, and being able to help connect organisational priorities with what QI learners can actually apply what they're studying to. And the last point was about prioritisation. It was about kind of perhaps stopping trying to do too much all at once, or trying to be all things to all people when we're tackling these sorts of challenges, and help people to use data and use their insights to narrow the scope of what they're looking at, and focus in on priorities and work on those to get that.
Fantastic, thanks so much, Kath. And then on to the fourth and final group, which had John, Mark, and Sam.
Hi, Matthew. Yeah, I'm happy to feedback. So yeah, we did have some really rich discussions, I think, just kind of going around the team from our different kind of perspectives and approaches and roles. And yeah, I think for ourselves, we kind of looked at, it's about providing those out there with basic improvement tech tools and techniques, just to be able to equip them with the tools they may need going forward. Because I think it's easy from a higher position, possibly from different levels and different hierarchies, to try and inform change. But I think on occasion, we discussed the lack of transparency or communication. Again, it's something being brought in. So say it was a form, and when the examples was used, it wasn't known where the form would come from. It was just a case that get rid of all your other forms, and this is what you're now going to use. But they had lack of understanding of where this came from. So I think from what we discussed is communication is critical. And it's just about sometimes going down to those areas and go down to the kind of where the work is happening, wherever it may be, whether it's clinicians, front ends, whether it's in offices, doesn't really matter. It's about going there and understanding, because we said about data capture is just so important. But again, data can inform where you may have some issues or some things occurring. But I think until you go down and go into a look-see, it's hard to understand really what the nuances are, or where maybe some of the improvements can be made, because I think it's those people who are actually carrying out the tasks on the front end or wherever it may be. It's going to speak to them and say, look, what are your issues? And just trying to listen to them, and not just kind of in a plastic sense. So it's really kind of just embedding and just discussing with them, because sometimes the perception is, well, we'd love to make that change, but we're told, no, we're too busy. We haven't got time to make that change. So just get back on to your work now. And I think the feeling is that sometimes the system's gone hard, where people don't feel like they have that either psychological safety or capacity in some sense. They're always sometimes it's always the thought that you're too busy to improve. You haven't got time to slow down. But when we do slow down and notice these things and actually look to implement and affect change, that's where we can then free up the system down the line. So it's about spending some money up front to make those time savings down the line. Another important aspect we discussed was around wellness and mental well-being. I think during the pandemic, it was really focused in on that, how are people doing? Are you working from home? Are you okay? The wall's closing in or not? How are you doing? Right, let's have a wellness session, then let's check in with each other. But now we've kind of emerging from the pandemic, even though we'll always be with COVID. It's just really kind of focusing, but then sometimes we do need to check in with each other still and just make sure that we are all doing okay.
Great, so thanks, Mark. So yeah, no, that's really useful points to share about. So really appreciate that, and for all the groups. I'm just going to hand back now, just conscious of time. So Rammya is going to open up for a short Q&A session. Thanks so much.
Yeah, thanks, Matt. We've got around 10 minutes for Q&A now. So I'm going to kick us off with the first question. But if anybody's got questions, please have a think, and then I'll bring you in straight after. So my question to the panel, so we've been looking back at the last 20 years or so, and we've been looking at what's worked and what we should potentially be doing more of. But I also think that improvement is as much about learning what we shouldn't be doing, learning from our mistakes, and learning what actually isn't going to work going forward. So have you got any reflections on that? What shouldn't we be doing going forward? I'm happy for anyone to come in out of the panel.
So let me kick off. I think it's important that the centre understands that its role is to create the conditions to create points of connection and bridges for people. But unless there is a large programme that needs central funding, it should reverse out of telling organisations and systems what they should do. So very much condition creating rather than directing. A belief that I have is that whatever organisation you're in, whether it's a whole national system or a local one, the solutions are better found deep inside the organisation rather than at the top of it.
Yeah, absolutely, David. That certainly resonates. John, sorry, seen your hand up.
Thank you. I think two things for me is that I think the first one is that we've got very good at building QI hubs, but maybe we've lost the link between senior leadership and the QI teams, and actually really get leadership back working with improvement and really understanding how they support it. I think the second one for me, Rami, is it's very much around priorities. I think we're very good at creating an industry of improvers, which is fine when we're training people, but actually what would be really helpful is to really think about how we line up improvement knowledge and expertise to a couple of big priorities, as opposed to spreading it so thin is that we maybe not necessarily get the impact we'd hope for.
Great, thank you, John. Ailsa, have you got anything else you want to add? Yeah, do come in, Ailsa.
Sorry, Ronnie, I froze for a second then, so I've turned my camera off. I think the only thing I'd add is that we shouldn't chase the performance targets, because I think one of the things that we are in danger of doing is actually chasing the target rather than really focusing on the improvements we want to see for our patients and our staff. So whilst it's tempting to, I think we really should try and avoid that.
Thanks, all. I'm going to open it out to the floor now. So if you do want to come, please just raise your hand and I'll call you in. Inviting both comments or questions to the panel. Kath.
Hi, I think it's a reflection thinking about my recent work as an improvement advisor, and I kind of have three things in my portfolio of things I do day to day. One of them is teaching on building capability. The other is being a resource into a clinical directorate that helps them own how they use QI, and I help them build their support structures. So who are their sponsors, who are their coaches, who are their leaders leading work that matters, and how does that work come from both what directorate management teams feel are those highest, most kind of priority areas, and how do the people who are learning also get to use QI to learn on the right things for them. And then the third part of the portfolio is about the high priority areas in the organisation and how can we support those more closely. So it's kind of three things, and I just, as a reflection, I found that balances my contribution as an improvement advisor to the organisation. So yeah, just offering that as a reflection of kind of sense making through listening to what people are saying we can do to help address some of these kind of current challenges at different levels. I hope that's helpful.
Yeah, thanks, Gav. That is really helpful. Would anybody else like to come in? Des.
Thank you. Yeah, so I think one of the things, I'm picking up on John's point about leadership and that connection to QI. For me, there's something about, and I think it's going back to Ailsa's point earlier around connecting learning at all levels of the system. I think that's so important, and connecting it in a way that is experiential. It's not just about that rational approach to, I'll send the exec a report. I think execs, policy leads, others within the system need to have a real first-hand understanding of the challenges and the experiences of QI when you're trying to make a change for people within the context of their lives. So I think that connection needs to be more than a transactional report, for example. So yeah.
Thanks, Darren?
I'm interested in what people think about how we make the time for improvement, because when we tried to do this last time, 20 odd years ago, a lot of our response was throwing capacity and investment at the problem. That's clearly something we're not going to have the opportunity to do now, but improvement is likely to take time to get traction on some of the problems we've got around waiting lists. And how do we buy that time?
Ailsa, are you okay to come in first on this?
I am so sorry, Rammya, the connection dipped out. Could you just repeat that?
So I think Darren's question was around how do we make the time for improvement given the current constraints. So yeah, just inviting a response from the panel.
Okay, yeah, happy to go first. So it's not easy, Darren, is the first thing to say. But I think what the executive team prioritises, what the organisation prioritises. So I've put something in the chat, we've really tried to learn from David's approach in Salford. So when I worked in Salford, I observed David really supporting improvement personally and the rest of the board doing the same. So about half of our executive team now coach improvement in our organisation, and we've made a commitment for our senior leadership team to complete the improvement programmes, because if our chief nurse is able to coach a big room every week, it gives a really clear signal that that's a priority, and that, you know, we're expecting everybody to improve as well as doing their job. So I think if you can have the conversation about what is it for you and your organisation, yours may be different, but what would you do in your organisation that would signal the importance of improvement?
Thank you. John or David, have you got any further reflections on that?
I'd reinforce what Ailsa said. I think it's not the easiest of conversations to have, but just the importance of leadership and it being, you know, led by the CEO, and not to embarrass David, is that I think he did it so very well in Salford. I think the other one in terms of time is you know, there's lots of evidence of good improvement work in places like the critical care units and on wards, because we can measure it easily and we see the impact of the improvement work fairly quickly. If you're working on outpatient waiting lists and you're doing an improvement program, that PDSA cycle may take 6 weeks, if not 3 months, to actually play itself out. So I think there's something about sort of patience and holding your nerve as well as finding the time to actually do it.
And if I may, I had just a marvellous experience, although I probably wouldn't repeat it again, of going into Liverpool last year and really thinking through with the leadership team what should be done. And to Darren's point about how you create the time. So we went back to basics in producing an organizational driver diagram of what it was we wanted to achieve and what were the things we were going to do around leadership, methodology, measurement and building capability, and then the application of those to a limited number of priorities. And we made that explicit into the organization within a few months of saying, well, this is now what we're going to do. And I think the biggest point for me of learning over this last year was the need to reconnect with the middle of the organization. I don't want to be disparaging to the previous leadership team, but I think something had been lost. And I don't know whether that's people's experience, that there were a lot of orders and direction coming from the top, and people had started to shrug their shoulders. And I think creating the time for people to consider means that you have to, as a senior leadership team, give them that time, meet with them, listen to them without telling them what it is that they should be doing in that first instance, but then trying to simplify it and say, look, do you agree that these are the things that we should be spending our time on? So a great learning experience for me, but connecting with the middle of the organization is hugely important to give people the time to express themselves.
Great, thanks. So the time has just run away from us, and unfortunately we've come to the end of our Q&A session. So I just want to take the opportunity to thank our panel members, Ailsa, David and John, and also for all of you who've been part of this discussion and made it as rich as it has been. I guess my sort of final reflections are that the challenge is huge, but actually we've got a lot of the building blocks. And it also sounds like every trust and every bit of healthcare needs a Sir David Dalton, by the sounds of what everyone has been saying today. I think that sort of senior exec involvement and championing of improvement is going to be key, isn't it? I'm going to hand over to Matt now, who's going to just check us out. And yeah, thank you, Matt. Go on.
Great stuff. Thanks, Rammya. And yeah, huge thank you to you as well for chairing the session and discussion there so well. Yeah, just two things from me. Just to let you know about the rest of the day. So we've got a lunch break now. There are a few activities going on over lunch, but then the next kind of parallel sessions start again at 1:45. So do please take a break and then join us for those. And then just finally, Sarah will launch it just now. We've just got a really short evaluation poll. It's literally 2 questions. It'll just take 15 or 20 seconds. It'd be great. We'd really value a bit of feedback on the session. Obviously, a lot of kind of thought and work goes into designing them. So in the spirit of improvement, it'd be great if you could share a bit of quick feedback with us. Otherwise, great stuff. Thanks again to everyone. And yeah, look forward to seeing you this afternoon.